Good afternoon, everyone. I'm delighted to welcome all of you to this important educational seminar today, focused on a preventive health concern that is quietly affecting millions of people worldwide, non-alcoholic fatty liver disease, or as we call it, NAFLD. Today we have with us Dr. Inder Kishore Singh, who is a senior consultant from Safdarjung Hospital. He shall be giving us a brief talk on this topic. I would request all of you to post your queries in the chat box as the lecture progresses. We shall take these queries one by one at the end of the CME. Also, please note that we are in the process of shifting to YouTube platform, so if there are any technical difficulties, please mention the same in the comment box as well. Thank you. Now I would like to hand over the mic to the sirs so that we can start with the presentation.
Thank you, Doctor. Good evening, everyone. I am Dr. Inder Kishore Singh, a medical specialist from Safdarjung Hospital. Today, very important topic I am going to discuss about non-alcoholic fatty liver disease. This will be covered in following headings: definition, incidence, prevalence and screening, risk factors, pathogenesis, clinical features, diagnosis and management. Basically, nowadays, name of the NAFLD is changing. Non-alcoholic fatty liver disease is not changing to MFLD, metabolic associated fatty liver disease. A lot of countries, a lot of societies accepted the term metabolic associated fatty liver disease. But in our context, in Indian context, in Asian context, name is still there similar to before NAFLD, non-alcoholic fatty liver disease. Definition of non-alcoholic fatty liver disease is excessive fatty accumulation, fat accumulation with insulin resistance, which occurs over 5% of the hepatocytes. After the exclusion of the secondary causes of the fatty liver disease, that should be labeled as the non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease may be isolated fatty liver disease, NASH, non-alcoholic steatohepatitis, then eventually converted into hepatocellular carcinoma. Isolated fatty liver disease, that is non-alcoholic fatty liver disease, is pure steatosis. Only the fatty liver is there, fatty accumulation, fatty acid accumulation, triglyceride accumulation is there, but mild lobular inflammation may be there, but injury is not there. So isolated fatty liver disease is NAFL. After that, if severe injury is there, lobular inflammation is there, that will convert it into non-alcoholic steatohepatitis. Non-alcoholic steatohepatitis may be early NASH, may be fibrotic NASH, may be cirrhotic NASH. Early NASH is on liver biopsy, it will be F0, F1 fibrosis. Fibrotic NASH will be F2, F3 fibrosis, and cirrhotic NASH will be F4 fibrosis. Eventually, the cirrhotic fibrosis will be converted into NASH in few of the patients. Definitive diagnosis of NASH requires the liver biopsy. Now the natural history of the non-alcoholic fatty liver disease. We are considering here only the NAFLD, not MFLD, but nomenclature is slowly changing worldwide. Non-alcoholic fatty liver disease in 70 to 75% is isolated fatty liver disease, 20 to 25% is non-alcoholic steatohepatitis. Steatohepatitis may be converting from isolated fatty liver disease after a lot of other injuries. Non-alcoholic steatohepatitis in 11% after 15 years may be converted into non-alcoholic steatohepatitis cirrhosis. That cirrhosis may be decompensated in 19 to 45% over 7 to 10 years, and 7 to 2% after 6 to 5 years may be converting into hepatocellular carcinoma. This is the natural history of the non-alcoholic fatty liver disease, in which non-alcoholic fatty liver disease, isolated fatty liver disease, initial finding, after that NASH converting into NASH, after that NASH cirrhosis, and after that decompensation or hepatic cellular carcinoma may be there. Now they come to the screening, prevalence and incidence of the non-alcoholic fatty liver disease. Worldwide, this disorder is very much common in Western societies. This is 17 to 46% of the adults, which is parallel to the metabolic syndrome and its component. Risk of the NAFLD is day by day increasing. In our scenario, this is 1 in 3 adults. We have the patients in Indian scenario, in Asian population, about 33%. NAFLD may be also seen in the case of lean. Lean means lean NASH. Can say lean NASH in the 7% of the population. Usually the NAFLD is seen in the obesity, in the metabolic syndrome. But if BMI is less than 23, we are considering in the our population, in the Asian population, lean NASH may be seen in the 7% of the patient. Available data suggests that approximately 1 in 3 patients of the in children also NAFLD in India is there. It is estimated that 16 to 32% of the general population in India has NAFLD. Among them, about 31% are diagnosed with NASH. Industrialization and change in lifestyle and diet with less physical activity and increased calorie-rich food are contributing to the increased prevalence of NAFLD in Indian population. Some screening recommendation is there in different society. Here patient with insulin resistance and metabolic risk factors are there like obesity and metabolic syndrome. That patient should be screened for the NAFLD. Screen individuals with the steatosis for secondary causes of NAFLD, including careful assessment of the alcohol intake. If patient's alcohol intake is more than 21 drink per week in men, and in women 14 drink per week should be considered for the alcoholic liver disease. But below this level, a screening for non-alcoholic fatty liver disease should be done. Identify other chronic liver disease that may coexist with non-alcoholic fatty liver disease, as these might result in more severe liver injury. Now come to the risk factors of the non-alcoholic fatty liver disease. Usual risk factors are metabolic syndrome, and the components are obesity, type 2 diabetes mellitus, dyslipidemia, and other diseases are polycystic ovarian syndrome. These are the usual risk factor of the non-alcoholic fatty liver disease. Other conditions associated with non-alcoholic fatty liver disease are hypothyroidism, obstructive sleep apnea. In that obesities are there, so OSA is also a risk factor for the non-alcoholic fatty liver disease. And hypopituitarism, hypogonadism, pancreaticoduodenal resection, and psoriasis is also a risk factor for non-alcoholic fatty liver disease. Now come to the pathogenesis of the non-alcoholic fatty liver disease, which is a complex disease trait which arises due to the genetic and environmental modifiers. These two interactions, genetic and environmental factors, are the cause of the non-alcoholic fatty liver disease. In the genetics, PNP-LA3, these genes or mutations are very important in the pathogenesis of the NAFLD. Normal liver, when converted into hepatic steatosis, after the genetic and genetically predisposed patient and environment is converting into the non-alcoholic steatohepatitis, after that cirrhosis may occur. Other hypotheses are there, two-hit hypothesis and multi-hit hypothesis are there. When the normal liver is, first hit is due to sedentary lifestyle, high fat diet, insulin resistant and obesity, it is converting into simple steatosis. Only fatty liver will be there. But second hit, which is due to oxidative stress, causing the injury of the lobular inflammation will occur, and mitochondrial dysfunction, inflammatory cytokines, and gut dysbiosis. These all things will cause the non-alcoholic steatohepatitis, after eventually went into the cirrhosis and hepatocellular carcinoma. Worldwide, most accepted theory is the hypothesis is the multi-hit hypothesis. Multi-hit hypothesis, multiple insult acting together on genetically predisposed patient. That is insulin resistant, altered gut bacteria, inflammatory cytokines. These all multiple hits at multiple stages of the non-alcoholic fatty liver are there. So this multi-hit hypothesis is accepted worldwide. In the formation of the non-alcoholic fatty liver disease, most important thing is fatty acid accumulation, free fatty acid accumulation, and triglyceride accumulation. After the glucose in the circulation and free fatty acid circulation, it is absorbed inside the liver, and after esterification, it is converted into triglyceride. So these are the main pathogenesis of the non-alcoholic fatty liver disease. Now come to the clinical features of the NAFLD. Most of the patients are asymptomatic. There is no symptoms. Patient comes for other reason and was diagnosed there due to some other reason, ultrasound abdomen and other investigation, LFT is done. For that, asymptomatic patient may be diagnosed as non-alcoholic fatty liver disease. Other complaints are usually vague right upper quadrant pain, fatigue and malaise. Signs are hepatomegaly, large liver is there, but when converted into the cirrhosis, splenomegaly may be there due to portal hypertension, spider angiomata may be there, power erythema may be there, and ascites may be there. Now come to the diagnosis of the NAFLD. Before the diagnosis of the NAFLD, should be suspected that what are the risk factors are there, and after that evaluation should be started. Ongoing and recent alcohol consumption should be taken in the history. If the consumption is less than 21 standard drink per week, as already told, in the men, and in women more than less than 14 drinks per week is there, then patient should be suspected for the non-alcoholic fatty liver disease. So screening and evaluation should be done in these patients. Patient with unsuspected hepatic steatosis detected on imaging who have symptoms or signs attributable to liver disease or have abnormal liver chemistry should be evaluated as though they have suspected non-alcoholic fatty liver disease, and the workup should be done accordingly. Systematic screening of family members of NAFLD is not recommended currently. In the diagnosis of NAFLD, test to exclude the diagnosis of other cause of the fatty liver should be excluded initially. So all the viral markers should be done. Hepatitis B, hepatitis C, hepatitis A, hepatitis E should be done. If this is positive, then non-alcoholic fatty liver disease should be excluded. And if it is negative, then further investigation should be done. Alcohol-related liver disease, including alcoholic hepatitis, should be considered so that the NAFLD should be excluded. If autoimmune liver disease is there, then non-alcoholic fatty liver disease should be excluded. If congenital causes of chronic liver disease is there, like hereditary hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, polycystic ovarian syndrome, then if these findings are there, these diagnoses are there, then non-alcoholic fatty liver disease should be excluded. If drug-induced liver injury, lot of patients comes with psoriasis and taking the methotrexate and other drugs are also there. Then if fatty liver is there, then drug-induced liver disease, that is DILI, should be suspected. If DILI is there, then non-alcoholic fatty liver disease should be excluded. Now come to the laboratory investigation of the non-alcoholic fatty liver disease. 80% is in the normal range, LFT will be normal, in that OT, PT will be normal. But on the imaging, if USG is showing that grade 1, grade 2, grade 3 fatty liver disease is there, so that should be investigated further. So in the case of 80% of the patient, normal range of the LFT may be there. None of the currently used tests are specific for the diagnosis of NAFLD. Usually when LFT is deranged, OTPT is deranged, then the normal ALT level will be more than AST level. But when the AST level is reversed, AST level is more than LT level, then these things is suggesting cirrhosis may be going on. Higher AST LT levels and AST LT ratio are associated with NASH. The pattern of aminotransferase elevation don't provide a distinction between simple fatty liver and NASH. When hyperbilirubinemia is there, hypoalbuminemia is there, and abnormal prothrombin time is there, then these patients should be considered as cirrhosis. Cirrhosis investigation should be done further. When hyperglycemia, hypertriglyceridemia, and hypercholesterolemia are related to metabolic, these things are there. This is due to metabolic syndrome. Autoantibodies might be present at low titers, especially in advanced disease. So in many cases of NAFLD, some titer of autoantibodies may be positive, like ASMA and few ANA may be positive, but that will be the false positive. If ANA is there positive, and titer should be considered, and titer is, and according to modified autoimmune modified criteria, that should be considered for the autoimmune hepatitis. That should be done. If any positivity of the autoantibodies comes, then further investigation should be done to exclude the autoimmune liver disease. Now come to the imaging. Normally, normal appearance of the liver on the ultrasound is echogenicity of the liver will be equal to the or slightly greater than that of the renal cortex. As you seeing in the This is the liver parenchyma, and this one is the renal cortex. Here the echogenicity will be similar or slightly raised. But when abnormal fatty liver deposition is there, then the echogenicity will be high in compared to the periportal. These are the periportal area, and echogenicity will be different. And this one is the diaphragmatic echogenicity. So here all are visible. Echogenicity, higher echogenicity of the liver is there, liver parenchyma is there, and periportal is also visible, and the obscuration is not there. That obscuration of the diaphragm is not there. So this will be the grade 1 NAFLD fatty liver, grade 1 fatty liver. In grade 2 fatty liver, obscuration of the diaphragm will not be there, but periportal area, this echogenicity will be not visible. So this will be the grade 2. In grade 3, increased hepatic echogenicity will be there, but periportal here not visible, and diaphragmatic echogenicity will not be visible. So this will be the grade 3 according to the imaging on ultrasound. Ultrasound is widely accessible and inexpensive. So most initial test is ultrasound, which is usually done in our clinical practice. Limitation of the ultrasound, it is a qualitative only, quantitative measurement is not done on ultrasound, and suboptimal sensitivity and specificity for mild steatosis is also not. Limitation of the CT scan is suboptimal sensitivity and specificity for mild steatosis. But radiation exposure risk is very much, so limitation of the CT. So usually CT scan should not be done initially or later on also, should be avoided. But when there is confusion in diagnosis, some other focal lesions are there and SOL are there, then CT scan can be done. So first investigation is imaging is ultrasound. After that, most important is MRI. MRI usually. Best sensitivity and specificity for steatosis. Even mild steatosis is picked up in the MRI. Maybe superior to biopsy specimen in terms of establishing total hepatic fat. This can be used to follow patient longitudinally with treatment, but limitations are there. Not everywhere MRI is available, very expensive. So it should be considered for the on the diagnosis in DOT. Next investigations are the non-invasive biomarkers. Some panel of markers are there. These are markers are NAFLD fibrosis score, fibro test, BOD score, fibrometer, and FIB4. And one important is also APRI score, APRI, ASTN platelet ratio index. Most important among these are the FIB4 score. And FIB4 score parameters are age, AST, platelet, and ALT. Very easy to calculate. Sensitivity is very much high, 85%, specificity is 65%. When FIB4 scores are between 1.3 to 2.6, after calculating, calculators are there. So FIB4 scores are calculated from calculator. And when score is less than 1.3, there is no chance of any fibrosis. When score is between 1.3 and 2.67, then moderate risks are there. When score is more than 2.67, then high probability of fibrosis will be there. Next investigation is acoustic radiation force impulse ARFI. This is similar to ultrasound. This is done after using the ultrasound machine. It is alternative to the fibroscan, uses the sonoelastography that evaluates the liver elasticity. This utilizes acoustic waves to interrogate the mechanical stiffness of the liver. This can be used during a standard ultrasound examination of the liver. Diagnosis of significant fibrosis can be done by ARFI, but not commonly used. Only commonly used are fibroscan and ARFI, magnetic resonance elastography. One more, sorry. Next, most important investigation is fibroscan. Fibroscan is transient elastography that evaluates liver stiffness using pulse echo ultrasound. This is non-invasive test, most sensitive than serological biomarkers, which panel you are FIB4 or EPRI score, more sensitive than the non-invasive biomarkers. This evaluates a larger part of the liver. Main weakness in this is the interference by the steatosis with wave velocity. Very difficult to do in the obese patient. When the fibroscan scores some LSM score, that is liver stiffness measurement score, LSM score. When LSM score is measured in kilopascal, when this is between 3 to 7, then fibrosis score will be, according to liver biopsy correlation, will be F0 and F1. When more than 9 or around 9, the liver biopsy score will be on the F2. If between 9 to 40 kilopascal, it will be between the F2 and F4. If more than 40 kilopascals on the ultrasound, on the fibroscans, this measurement, LSM measurement is there, then the F4 fibrosis will be there. That means patient is going into the cirrhosis. Most important thing is the in the evaluation of the elastography is the magnetic resonance elastography. This is very expensive but very accurate in the diagnosis of the fibrosis in the case of NAFLD. Staging can also be done by the magnetic resonance elastography, and staging also correlating with the liver biopsy scoring. Next, most important and gold standard is the liver biopsy in the case of NAFLD. Accurate diagnosis can only be made by the liver biopsy. Indications are all the features of metabolic syndrome if there, and obesity is there. Liver biopsy if DOT from fibroscan and any other measurement, any other investigation is there, only the diagnosis can be made by the liver biopsy. Other indications are type 2 diabetes are there, and elevated liver transaminases are there. Other investigations are not in DOT, not diagnosing the case of NAFLD, then liver biopsy can be done. Other indications are normal BMI with elevated liver transaminases, and elastography greater than 6 kilopascals, an elevated value of the fibrosis scoring system. Reliable elastography value cannot be obtained because of the obesity. In that case, also liver biopsy should be done. If patient is not motivated for the loss of weight, then liver biopsy should be done to confirm the diagnosis of the NAFLD. After the biopsy is done, one score is there, that is the NASH activity score. NASH activity score is considering the steatosis score, that is S score, lobular inflammation score, L score, and hepatic ballooning degeneration score, that is the B score. After the summation of all the S score, L score, and B score, the diagnosis of the NASH is considered. When the score is more than 5 or 5, then NASH should be diagnosed confidently. When a score is 2 or less, then diagnosis of simple fatty liver can also be done, should also be done. In the S score, if liver steatosis, liver fat is less than 5%, score is 0. When 5 to 33%, score is 1. When 34 to 66%, score is 2. When more than 66%, score will be 3. This will be the S score. And lobular inflammation, that is L score. If no lobular inflammation is there, then L score will be 0. Less than 2 lobular inflammation, score is 1. 2 to 4 lobular inflammation is there, score will be 2. And when more than 4 lobular inflammation is there, then score will be 3. In the case of ballooning degeneration, if no ballooning degeneration is there, score will be 0. Few balloon is degenerated, balloon cells are there, then score will be 1. When many balloon degenerated cells are there, then score will be 2. And after the calculation NASH activity grade system, staging can be done of the NASH fibrosis stage. If NASH fibrosis stage, in that there is no 0 stage will be done by if none, every is normal. If score is 0, then stage will be 0. If mild and John Perry sinusoidal fibrosis there, then it will be graded as 1A. If moderate John 3 perisinusoidal fibrosis is there, grade will be 1B. If accordingly grading will be done. If bridging fibrosis is there, this will be graded as a stage 3 and cirrhosis stage 4. Sorry, not moving. Okay. Now next is the management of the non-alcoholic fatty liver disease. Most important and the most important is the lifestyle modification. This should be done along with the pharmacotherapy also. In the pharmacotherapy, we have only few drugs which is approved worldwide. Is no drug is approved, but in Indian scenario, few drugs are there: vitamin E, glitazone, saroglitazar, and obeticholic acid. And endoscopic and surgical bariatric surgery may be done for NAFLD. Approach to lifestyle modification is there. That should be the first and utmost important. Most important is the lifestyle modification. In that, energy restriction should be there. Caloric restriction should be 500 to 1000 per day, and loss of weight reduction should be 7 to 10% of the body weight, and long-term maintenance approach should be considered. Fructose intake should be low restricted, and daily alcohol intake should be less than, as previously told, 30 gram for men and 20 gram women. Better not to drink. And physical activity should be increased 150 to 200 minutes per week, moderate intensity in 3 to 5 sessions should be done. And some macronutrient composition, that lifestyle modification, low to fat, moderate fat should be taken, and moderate to high carbohydrate should be avoided, and low carbohydrate ketogenic diet should be taken. And coffee consumption is very important. Many liver diseases consider the coffee consumption should be advised to the patient. 2 to 3 coffee per day may be advised for the patient to drink. A percentage of weight loss associated with histological improvement in FLD is when weight loss is more than 10%, fibrosis regression is seen very much in the 45% of the population. When the weight loss is more than 7%, NASH resolution is seen in 64 to 90% of the patient. When weight loss is more than 5%, ballooning inflammation, ballooning degeneration and lobular inflammation is seen in 45 to 100% of the patient. When weight loss is more than 3%, simple steatosis, fatty liver in the case of 35 to 100% of patients are seen. Reduction in the liver fat. Not moving. Now come to the pharmacological treatment of the patient. Lifestyle modification is the most important, in which calorie restriction, exercise, that things are important. But when grade of the fatty liver is there, grade 2, grade 3, then pharmacological treatment should be considered. In that, vitamin E is very much important, which is not approved but is widely used worldwide. And the next drug in Indian scenario is the pioglitazone, which is also not approved, but in Indian context can be used. Metformin is also considered for the NAFLD treatment, but not approved. Pentoxifylline is also considered, but not approved. And other drugs are in phase 2 or phase 3 trial are elafibranor, PPAR, alpha and delta agonist, and obeticholic acid is a FXR agonist, which is also not approved. Only 2 drugs in India is bi-nasal is approved, which is saroglitazar and vitamin E. Vitamin E is also not approved but widely used. Currently available agents targeting insulin resistance are pioglitazone, liraglutide, semaglutide, exenatide, canagliflozin, empagliflozin, and saroglitazar. These are the drugs currently in the phase 2 and phase 3 trials. Some recommendation by AASLD is there on pharmacotherapy. Metformin is not recommended for treating NASH in adult patients. Pioglitazone improves liver histology in patients with or without type 2 diabetes mellitus with biopsy-proven NASH. Therefore, it may be used to treat these patients. Until further data supports its efficacy and safety, pioglitazone should not be used to treat NAFLD without biopsy-proven NASH. It is premature to consider GLP-1 agonist to specifically treat liver disease in patients with NAFLD and NASH. Vitamin E administered at a daily dose of 800 international units per day improves liver histology in non-diabetic patients with biopsy-proven NASH. Therefore, may be considered for this patient population. But recent studies show that vitamin E can also be used in diabetes also. Until further data supporting its effectiveness become available, vitamin E is not recommended to treat NASH in diabetic patients. NAFLD without liver biopsy, NASH cirrhosis, and cryptogenic cirrhosis. Also, deoxycholic acid is not recommended for the treatment of NAFLD or NASH. Omega-3 fatty acids should not be used as a specific treatment of NAFLD or NASH, but that may be considered to treat hypertriglyceridemia in patients with NAFLD. Patients with NAFLD should not consume heavy amount of alcohol. Statins can be used to treat dyslipidemia in patients with NAFLD and NASH. While statins may be used in patients with NASH cirrhosis, they should be avoided in patients with decompensated cirrhosis. Obeticholics should not be used off-label to treat NASH patients. Careful attention should be paid to identify cardiovascular disease, whether clinically apparent or occult, during the transplant evaluation process. Now, the safety and tolerability of the vitamin E and pioglitazone. Vitamin E in the dose of 800 international units per day for 1 year, there is increased hemorrhagic stroke risk. So, this should be considered in mind. Also shows reduced ischemic stroke risk. This vitamin E also increased prostate carcinoma risk, particularly in type 2 diabetes. But in many studies, this was not accepted, and in type 2 diabetes mellitus, vitamin E was also used. Pioglitazone side effect is edema and weight gain. Risk for osteoporosis in women are there. And the side effects, one important side effect of pioglitazone is equivocal bladder cancer risk. Most important drug which is approved by DCGI is saroglitazar. Saroglitazar was first used in 2013 in diabetic dyslipidemia, and after that in type 2 diabetes mellitus in 2020, and in March, non-cirrhotic patient, NASH patient, saroglitazar was used. But now in AASLD, Indian National Study of Liver Disease, that society also considering the saroglitazar as the treatment of choice, not treatment of choice, but it's approved, this drug is approved for the NAFLD. So from 2021, NAFLD with comorbidities should be treated by saroglitazar 4 milligram. Now the prognosis of the non-alcoholic fatty liver disease. Overall mortality is increased compared to the matched control population. Commonest cause of death in the patients of NAFLD is cardiovascular disease. There is increased liver-related mortality, so the increasingly common indication for the liver transplantation. Causes of mortality in cirrhotic NASH patients are sepsis, liver failure, variceal hemorrhage, hepatocellular carcinoma, and cardiovascular disease. Thank you for your patience and kind attention.
Thank you, sir. Thank you for the wonderful talk on the topic. I hope that every one of us gained something out of the lecture. Now, I would ask everyone to post their questions in the chat box so that we can take up with the sir. Meanwhile, we have few questions, sir. First of all, we have a question on grade 1 and grade 2 NAFLD. Dr. Seturaman is asking, should we treat grade 1 and grade 2 disease, sir?
Yes, in our AASL also proposing that NAFLD should be treated from a start. If
Okay,
grade
sir.
1 is there, that should also be treated. If grade 2, grade 3 already we are treating, but grade 1 should also be treated actively.
Thank you, sir. That covers the question that the fellow doctor asked. Now, the second question is, sir, on the approach in a primary care setup. Dr. Anand is asking, what should be our approach? Because we, as a facility, have a lot of primary care physicians. So, what should our approach towards that be? And he's also asking if there is utility of any of insulin resistance markers in a primary care setup.
Yes, initial approach should be when patient of any metabolic syndrome like obesity is there, dyslipidemia is there, type 2 diabetes is there, that should be screened initially. Initial LFT should be done, and imaging if available, that is everywhere available, that should be done. If looking like that NAFLD is there, that should be treated accordingly. Insulin resistant score is there. One score is there. Accordingly, the treatment is done according to insulin resistant score. But in our scenario, few drugs are there, insulin resistant drugs, which is targeting on insulin resistant. That is semaglutide, GLP-1 analogs are that all are insulin resistant, targeting on insulin resistant. So most important things are drugs. Semaglutide can be used, and liraglutide can be used. These drugs can be used. If in semaglutide, particularly if loss of weight is there after using that semaglutide, and empagliflozin also, if loss of weight is there, there must be some benefit on the NAFLD also. But these drugs are not approved. These in all the clinical trials are there.
Thank you, sir. That covers the question in detail. Another question, sir, we have on drugs. There are two questions. Dr. CJ is asking, are there any drugs that can cause NAFLD? There's another question, can indigenous or native medications cause NAFLD?
NAFLD you can cause. Fatty liver may be caused by the many drugs. Methotrexate might cause fatty liver. These drugs, which is usually giving in the psoriasis and other rheumatoid arthritis patient, fatty liver may be there, may be caused by that. But drug daily should be considered first. If drug induced liver injury is there, that should be excluded. On liver biopsy, histological finding will be different from the NAFLD. So methotrexate when using, or any drugs are using, that liver biopsy finding will be different from NAFLD.
Okay, sir. So we have one question on pioglitazone. One doctor is asking, can pioglitazone be considered in non-diabetic patients?
Usually not.
Okay.
If diabetes is not there, that should not be considered, because lifestyle modification is most important if non-diabetic patient is there and vitamin E is also there. Why using pioglitazone?
Okay, sir. One question is on LFT, sir. Dr. Anush is asking, is GGT increased in NAFLD? And if yes, what would be the treatment to decrease it?
No, we have not to decrease the level of the GGT. If GGT is increased, then significant alcohol intake should be considered in mind.
Okay, sir. If anyone has any more questions, so we can take it up. Otherwise, we can end the stream. I think, sir, we have discussed the whole topic in detail. We have also discussed the questions.
Yes.
Once again, I thank sir for the very wonderful presentation, and I ask everyone to join the stream on CME on the first Tuesday of the next month. Thank you so much.
Thank you. Thank you.
बढ़िया